So once again, we continue with our project looking at particular motions and making that the specific or the central portion of our network of meaning or our semantic network with respect to understanding anatomy. Now, at this point, we're looking at shoulder internal rotation. And shoulder internal rotation is a term that one would think is extremely specific, and it is. However, there are varying positions at which it can take place. We'll talk about this when we talk about planes and axes. But before we even do that, we want to understand that at least in anatomy, what's usually happening is you're referring to the anatomical position. So with respect to the arms would be at the side and the palms would be up or in a supinated position. That would be considered anatomical neutral. So terms for movement would be noted based on that position or from that position. But I'll let you know why that may not always be the perfect way to use internal rotation with respect to the shoulder, and even why that may not matter as much as I'm even making it out to be at this moment. But either way, our main objectives here, a specific discussion of what shoulder internal rotation is, the planes and axes, which is where I'll talk about how the term internal rotation can refer to the same motion, but in different planes. The general discussion, we'll have a general discussion of the muscles that internally rotate the shoulder. We'll have a very general discussion of the nerves that supply those muscles. General discussion of vascular supply, so we'll really look at it more or less in the neurovascular bundle. A general discussion of the areas to assess and treat should shoulder internal rotation issues be suspected or reported. So our quick review of planes. So the sagittal plane cuts the body 50% left and right. So it's a cut right down the middle, left and right. Horizontal or transverse plane is a 50% cut of the bottom top to bottom. The frontal plane is a 50% cut of the bottom back to front, also called the coronal plane. Now, in the anatomical position or in anatomical neutral with the palms up, so I can't really show this to you properly on the screen, but if you bend the elbow to, this is above 90 degrees, then internal rotation would be towards the midline of the body. Some people will call this, or some resources will call this medial rotation or rotation towards the middle, contrasted with external rotation or rotation away from the middle, lateral rotation. Now, internal rotation can also happen up here. So it's towards the floor, right? So this would be rotation in the transverse plane. So standard internal rotation is in the transverse plane. Now, there is no absolute clear axis. This is mostly made by the muscular connections to the shoulder because the glenohumeral joint is multiaxial and multiplanar. You've got the big ball and the little socket. So the big ball of the humerus, the little socket of the glenoid, leading to a lot of mobility. But here, this is also internal rotation. But internal rotation in this position is now in more or less in the sagittal plane. So you can have internal or medial rotation happening in different planes, but either way, what you can say is happening that's the same is it's rotating towards the middle, right? Towards the middle of the plane, but you'd have to consider midline of the body, right? Either way, internal rotation in the standard sense is in the transverse plane. Yeah, it's in the transverse plane. I'm going crazy. And then here it's in the sagittal plane. I don't know of anybody that can absolutely do it in the coronal plane. Actually, that's the left coronal plane right there. There we go, coronal plane. So you bring the elbow to the middle and you go in the coronal plane. So that's internal rotation in the coronal plane. So it's still going towards the middle. So that might be one way to prefer the term medial rotation, because medial rotation can make it make sense in different planes, but the same movement can happen in all three planes, just depends on where the arm is. And then it can happen in between planes because the glenohumeral joint is multiaxial and multiplanar. So if we look at the internal rotators, so we've just got a general schematic of the shoulder girdle and the muscles of the shoulder girdle, but pectoralis major, the anterior fibers of the deltoid, latissimus dorsi, teres major, and subscapularis, I believe, are all three, or sorry, not three, all of the muscles that will generally generate internal rotation. One of the things when you look at the lat being on the back, you would think it may be a little bit more likely if you don't understand the more proximal attachment to create external rotation. What ends up happening is it goes almost towards the front of the humerus. So it's a little bit more in the midline, because it goes more from the back, from the posterior surface of the body, closer to an anterior position on the humerus, or midline anterior sort of, then that proximal attachment allows for it to have that line of pull. Teres major also does that. It goes from the scapula and it shoots a little bit more forwards on the humerus. So its pull is going to allow for that internal rotation. Pectoralis major, it makes a bit more sense, as do the anterior fibers of the deltoid, based on them being on the front of the body. Subscapularis being on the anterior surface, so from the anterior medial border, or the anterior portion of the medial border of the scap, through this to the anterior portion of the scap, essentially attaching to the anterior surface of the scapula, and then going to the humerus as well. It makes more sense how that can generate the internal rotation. The lat and the teres major are a little bit more confusing if you see them in a two-dimensional image, but if you see a little bit more depth or another dimension, then so instead of seeing it in 2D, you'd see it in 3D. That would make a little bit more sense, but those are internal rotators. As far as the neurovascular bundle, anything with the shoulder, you're considering more or less the same stuff, right? So you're considering, depending on the particular muscle that you're looking at, branches directly off of the subclavian artery, draining into the subclavian vein, right? So you're more or less having the same names for the vessels on the artery and the vein as they branch off of the artery or onto the vein or into the vein, however you'd like to term that. Then you're looking at branches off of the axillary artery more here. So the pec is going to get it more off the axillary artery. You're going to have some going back off of, I believe, the thyrocervical trunk to get into the not supraspinatus, but into the lat, if memory serves properly. And then as far as everything else, all the other muscles noted, you're getting off of the axillary circulation. The nerves, so for the pectoral, for pec major, you've got the pectoral nerve, so medial and lateral pectoral. For the subscap, you have upper and lower subscap. You have the thoracodorsal nerve for the lat, and then teres major. That one I'm blanking on, but more or less what you're looking at is the same pathway, regardless of the specific nerves. You're looking at the same pathway. So you're considering the relationship between the scalenes, anterior and middle scalene, and the SCM. So SCM and the anterior scalene, as far as the venous system is concerned, or the venous portion of the subclavian circulation, the anterior and middle scalene for the artery, the anterior and middle scalene for the, essentially as a portion of the thoracic outlet or the thoracic portion of the brachial plexus and its passage. The clavicle, you're thinking about the pectoralis major and the pectoralis minor is essentially the roof of the axilla. You're thinking about the subscap as the floor. You're thinking about all these things as far as the general neurovascular bundle, which leads to why you're going to, regardless of what the issue for the shoulder is, you're going to look at all of these areas in order to consider the neurovascular bundle and to consider the muscles themselves. So usually in a shoulder assessment and shoulder treatment, you're checking all of the borders of the scapula, you're checking the glenohumeral joint itself, you're going to check the neck, you're going to check the clavicle rather, you're going to check all of these things and treat as is needed, almost regardless of the particular dysfunction. As far as the particular dysfunction is concerned, you're definitely going to consider that motion, but you still have to check all those other areas just because of how the neurovascular bundle for almost anything in the shoulder or even in the upper limb is going to have the same path or same paths. So with respect to internal rotation, as I already noted, what you're going to consider for assessment and treatment, you're going to consider the clavicle, right? How is the clavicle moving? So that's neurovascular bundle. The thoracocervical column, generally speaking. So that's more the neural bundle, but also the neurovascular bundle because of how the scalenes attach from the cervical column to the upper two ribs. The thoracic column, generally speaking, and its influence on not only the ribs, but its influence on some of the muscles to the scapula, so the trapezius and the rhomboids. You're going to consider all borders of the scapula. So you've got the medial border, you've got the lateral border more or less. So essentially right in here, you call that lateral. And then you have the anterior, you could call it the anterior border, but it's basically the pectoral tissues. And all of that is also, again, neurovascular bundle, but in there, depending on this particular motion that you're looking at. So as far as internal rotation is concerned, internal rotation is more the anterior surface and the lateral border. But if the scapula is moving somewhat oddly in relation to the thoracic column and to the cervical column, then you'll also have to do something about the medial border of the scapula. So you check all the borders, as I already noted, the pectoral muscles and the ribs. So you're going to check all of those areas for motion dysfunction and their contributing factors with respect to internal rotation in this case. Now, if there is a known fracture or tear, you do not treat. If there's a suspected fracture or tear, you send out for further diagnostic. Depending on the particular region that you work in, you may send to a physician, you may send to a nurse practitioner. It's going to vary. But a known tear, you don't treat. So a known fracture or tear, you don't treat. A suspected fracture or tear, anywhere in the areas of consideration, you send out for further diagnostic. Any recent dramatic changes in cognitive functions, you don't need to know what specifically is going on, but anything that is a major recent change in cognitive function, you're not going to treat, because that could be something with respect to the blood flow to or from the head. That could be something with respect to recent trauma, so it could be a concussion possibly, but you'd usually know that because the trauma would be more obvious. But anything with the neck or head, as far as recent dramatic changes in cognitive function, send that out, don't treat it. Recent dramatic changes in respiration, which is because of the relationship here between the ribs and the scapula, right? And the areas that you're working in is also including the pectoral tissues. You're going to send that out. You're not going to treat that. You're going to send that out for further medical investigation.